Hello everyone. Welcome to the most awaiting emerging Med Talk. I know you are going to stick around as this series will be loaded with 100% simplified practical approach that are guaranteed not only to bring your attention but also make the topic understandable. And lastly, the 10 important points, the tips particularly, will be the game changer for your confidence. So, this series of X-ray, that is reflection, will be helpful for all my colleagues, then PGs, interns, all my MBBS, BMS, BHMS, BDS, BPTH, these all nursing, BPMT, all paramedical and technical students. So, this is Professor Dr. Prashant Busari welcomes you on this emerging Med Talk. Topic of discussion is practical approach to chest X-ray, that is chest radiograph, and how the anatomical landmarks reflect on the chest. We will discuss step by step. So this is the chest X-ray. So we'll discuss now practical approach. So here is the chest X-ray, that is side is right side. So this is right side and the projection is posterior anterior. The X-ray beam passes from the patient posteriorly and the cassette is placed in front of the patient. So posterior anterior projection, that is PA view. Then another mnemonic, it will be the eyes. So I, that is inspiration. So proper inspiration, so anteriorly around 5 to 6 ribs will be present, anterior ends above the diaphragm, and 8 to 10 posterior ends will be above the diaphragm. C, well centered, that is the spinous process equidistant from the medial ends of the clavicle. Then the exposure, so proper exposure, so above 4 thoracic vertebrae where is seen clearly and below will be barely visible. So this is in short eyes. Then we'll start the reading this chest X-ray under this what we can say the ABCD approach. A for airways, B for bone, C for cardiac shadow, D for diaphragm, and E for effective lung field. Before that, very important two densities are important, that is radiolucent, that is black radiolucent, and particularly related to lung, and radio opaque, that is related to white, that is bone, metals, or the some soft tissues. So approach is ABCD. So here is the, that is A, airway, that related to trachea. So here we can see these translucent shadow in the midline. So that is nothing but of trachea. So this is translucent shadow, midline tubular structure in the upper part of the chest, and it bifurcates into right principal bronchus and left principal bronchus at the level of the around fourth lower border of the thoracic vertebra. That angle of bifurcation we called it as carina. That is nothing but the bottom of the sheep, and angle is around 40 to 80 degrees. If it is more than 100 degree, there may be the left atrial enlargement. So we will see this airway here. So we can compare on the CT image and we can easily see the trachea. This is right principal bronchus, left principal bronchus, and the carina. So it is midline and around 10 to 12 centimeter in the neonate, particular newborn. It may be around 4 to 5 centimeter, and if it may pull opposite, here is the pleural effusion, it pulled opposite side in the pleural effusion and it is shifted towards the side that is in the volume loss, that is collapse of the lung. So this is airway. Second will be the bones. Second will be, so bones particularly. So here we can see the on east side the clavicle, the horizontal long bone, that is horizontal place long bone on each side, and this is medial end. Here is the what we can say the lateral end of the clavicle, and medial end, both they are equidistant from the spinous process of the thoracic vertebra, and it medial end articulates with the sternum to form the sternoclavicular joint, which is of this saddle variety. This is collarbone. Then next will be will discuss about this shoulder blade, that is scapula. So here having this medial border, lateral border, then superior border. Here is a spinous process. Here is a inferior angle, then superior angle, and at laterally the glenoid cavity, it articulates with the that is head of the humerus to form the shoulder joint. Now very important, that is counting of ribs having anterior ends and the posterior ends. So we can see very well here the first rib. So here will be the first rib, and very important, that point of importance is anterior end of the first rib always lie just below the clavicle. So this is anterior end of the first rib. Here is the anterior end of the second rib. Here will be the anterior end of the third rib. Here will be the anterior end of fourth rib line. So these are the anterior ends, and and medially it articulates with these thoracic vertebra. So these will be the posterior end. So here will be the fourth, fifth, sixth, seventh, 8, 9, 10. These are the posterior ends of the ribs. Anterior ends, these looks like interrupted because these are articulate with the sternum through costal cartilage, and costal cartilage not seen clearly on the X-ray. So this is big difference. And also we will see the thoracic vertebra. So upper fourth thoracic very clearly, and lower will be the that barely visible. So these all will be the thoracic vertebra around, we can say the 12 thoracic vertebra. So we can compare these bones in this very simplified image. So we can see here the on each side, these are the clavicle, then here will be the shoulder blade, these will be the which ends, anterior. So this is important, these are the anterior ends, and on this medial side will be the what, these will be the posterior ends. So these are the anterior ends, and these will be posterior ends, and all these will be 12 thoracic vertebra. So this is very simple. Now why we are discussing these bones? So very simple here. Here is, we can say, break in the cortical continuity of the clavicle. So there is a cortical, we can say the fracture of the clavicle, and here also we can see there is a break in continuity of the ribs. So there is a fracture ribs. So after the B, we'll discuss third, that is also important, that is cardiac shadow, that is C. So the here important, the heart situated within the mediastinum between right and left lungs, and we can see here there are the two borders, right cardiac border and the left cardiac border. So here major portion of the right cardiac border is formed by right atrium, and above some portion by the superior vena cava, and below by the some portion by inferior vena cava. So main by the right atrium, and on the left side very important prominence or the projection we can see at this level is nothing but aortic knuckle. So this is what, aortic knuckle. Aortic knob. So this projection arises from the when the arch of aorta runs posterolaterally to become the descending thoracic aorta. At that point, it makes a projection of the prominence on the X-ray. This is what we call it as aortic knuckle or aortic knob. Just below will be here the what we can see the main pulmonary trunk with the branch left pulmonary artery, some portion by the left atrial appendage, and major portion by the what, left ventricle. So left cardiac border mainly contributed by the left ventricle, above by the left atrial appendage, then the main pulmonary artery with left this left branch, and above that projection is the aortic knuckle. Now here is important is cardiothoracic ratio. So that determines the size of the heart. So here when we draw the vertical line along this spinous process, so maximum diameter on the right side as a, maximum diameter on the left side as a B, and this maximum transfer diameter of the thorax as C. Then you know A plus B is always half that of the C. So half the diameter of the thorax. If the diameter of the thorax is 30 centimeter, then the diameter of cardiac will be around 15 to 16 centimeter, that is 50 to 55 percentage. So this is cardiothoracic ratio. So we can compare this cardiac shadow very clearly on this CT image. So we can see here on this right side, major contribution right atrium above superior vena cava, below some portion by the inferior vena cava. Then here is major portion on the left side will be the left ventricle. Here will be the left atrial appendage. Then main pulmonary trunk. Then above will be the aortic knuckle or the aortic knob. So this is very simplified, and the cardiothoracic ratio is 50 to 55% percentage, and if it increases, the condition is called as cardiomegaly. So this is why we are discussing the normal anatomy. So after this cardiac shadow, we will discuss the diaphragm. So here will be the right hemidiaphragm and here will be the left hemidiaphragm. So these are dome shape, these are not straight, and it makes an acute angle with the ribs or the lateral, we can say the thoracic wall, and on each side these angles called as right CP angle and left CP costophrenic angle. So these are around 30 degrees acute. It also makes angles with this right cardiac border and left cardiac border. So these angles, these cardiophrenic angles are also acute. Then we can see the here, this is a fundic shadow just below the left dome of diaphragm, and this is normally situated. If it is on the right side, then the condition is abnormal, that is maybe due to perforation. So now we can this correlate simultaneously with the CT image. So this is right hemidiaphragm, the left hemidiaphragm making angle with the lateral wall forming the costophrenic, and here as a cardiophrenic angles. So very simplified, and these angles will be obliterated. Here this angle of the on this left side obliterated in the condition called as pleural effusion, and here also we can see there is no cardiophrenic angle seen properly. The condition is due to maybe due to pericardial effusion. So this is why we are continuously discussing the normal anatomy. Then after this what we can say diaphragm, we will see the effective lung field. So lung parenchyma or the lung field. So these are right lung, and here is the left lung, and here is the apex, here is the base of the lungs, and we can see normally some these tubular reticular on each side the radio opaque and shadows. These are normally present due to the bronchiovascular markings, and this radiologically lung divided into the three zones. So when we draw the horizontal line passing from the anterior ends of the second rib and anterior ends of the fourth rib, these divide into the upper, middle and lower lung zones. So above the second anterior rib is the upper, in between middle and below the fourth anterior rib line will be the lower lung zone. So this is very simplified, and there is no clear cut lucent shadow see here because it are having the bronchiovascular marking. So this is very important because this loss in the condition called as this pneumothorax. Then in this we will also see hilum, that is right hilum and left hilum. So this is right hilum on this side, and here is on this left hilum. So right and left, left hilum is always at a higher level than the right hilum. And so here we have seen these we can correlate here simultaneously. This is right lung, left lung, and having the three zones divided, and having these are the very clearly seen the bronchiovascular markings, which are seen clearly in the lower zone, particularly on the posterior anterior view. So we know, but some if any abnormal opacities, then we should know the conditions. So here we can say this radiopaque opacity defined in the right mid-lung zone. So it may be due to the consolidation if infective pneumonia. And here there is a volume loss on the right side and shifting of the trachea and mediastinum towards right side. So here is the condition, why what we call as collapse of the lung. So how this we have discussed. So this chest X-ray under these 5 headings: A, B, C, D, E pattern. A, airway; B, bones; C, cardiac shadow; D, diaphragm; E, effective lung fill. So here is how we'll see the normal X-ray here particularly. So there is this chest X-ray. If it is normal, how you to this report? So we'll see the chest X-ray. This is a posterior anterior view, and here projection technique is posterior anterior projection. Findings: both these lung fields are equally translucent. Then both the costophrenic and cardiophrenic angles are clear. Then the no hilar or mediastinal, we can say the mass. Then both the domes of diaphragm in normal contour and position. Then we can say the cardiac outline is normal, and also no obvious skeletal, you can say the abnormality or any fracture. So very simple. The impression will be no significant abnormality seen at present X-ray. So very simple, the normal X-ray. Then now if we know the normal, so how we can have some in brief the crux or the tips of these various points. So a very important, the anterior end of the first rib always lies just below the clavicle. Then right dome of diaphragm is always 1.5 to 2.5 centimeter above the left dome of diaphragm. Then left hilum is always at a higher level, around 1.5 to 2 centimeter than the, we can say, right hilum. Then this radiologically lung having three zones: upper, middle, and lower, and anatomically is different. And also there are the bronchiovascular markings normally present. So trachea bifurcates at the level of lower body of the fourth thoracic vertebra into right and left principal bronchus. That bifurcation is called as carina. Then clavicle plays somewhat obliquely in posterior anterior view and plays somewhat transversely horizontally straight in anterior posterior view. Then costal cartilage not visible on the X-ray. So the anterior ends, they are not continuous with the sternum, they looks as interrupted. Then we can see here this fundic gas bubble seen just below the left dome of diaphragm. Normally if it is placed, well, we can say below the right dome of diaphragm, it is abnormal presentation. It may be due to perforation. And we can see the costophrenic angles, they are obliterated, not seen, obscured in the condition called as pleural effusion, where the fluid accumulates within the pleural cavity, and cardiophrenic angle obliterated, obscured in this pericardial effusion. And lastly, when air trapped in the pleural cavity, we call it as pneumothorax. How to differentiate? Normally the lung, we can see the bronchiovascular markings, but here the bronchomuscular marking, they are totally absent. It looks all that translucent, and that may be due to the road traffic accident. So this is how we have discussed, very simple, the practical approach to the chest radiograph and the reporting and very important crux. So I think you like it. If any queries, any problems, any suggestions, please you can have add in the comment box. And this is just the beginning. So we have the lot of various X-ray series related to entire body, and you can subscribe for the further videos.